Ladies and gentlemen, it is time for the commencement of session 3 of oral presentations. Proceeding on this session will be our chairperson and judge, Dr. Jacqueline LANKA and Dr. K.C. Rapati. Mr. Uvinay will be joining us as the time. Before we commence this session, we would like to remind the presenters of the following. Each of you will have 7 minutes to present your research. At the end of your time, you will have a Q&A session of 3 minutes. The total time allocated per presenter, therefore, is 10 minutes. There will be one bell ring at the end of 5 minutes and 2 bell rings at the end of 7 minutes. With that being said, let us warmly welcome our first speaker of this session, Ms. Anupama U. to present their research on assessing the effects of delayed initiation of treatment on quality of life of patients with rheumatoid arthritis. Essentially, a patient consults their physician to start medication for determining the future. In the realm of rheumatoid arthritis, where the stakes are high and the broadly speaking, the timing of disease-modifying antiviral drugs, which is called as DMARDs, becomes a critical factor. Good evening, ladies and gentlemen. I'm Nirvana Anupama from Research Group 3. And the title of our research is Assessing the Effects of Delayed Initiation of DMARD Therapy on the quality of life of patients with rheumatoid arthritis. Rheumatoid arthritis is a chronic inflammatory disease which gives rise to immune deregulation with consequent joint inflammation. Typical presentation being chronic menstrual arthritis and systemic inflammation. Rheumatoid arthritis has 1% global prevalence with a million prevalence. Patients develop pain, joint stiffness, and deformities in joints, which seriously affect their daily life. Sleep disturbance and fatigue contained by sufferers such as cancer. So, the drug therapy for rheumatoid arthritis is not curative. It rather focuses on immune activity and improval of symptoms. Mainstay treatment is disease-modifying antiviral drugs, which is known as DMARD therapy, in which the effects usually takes about 2 to 3 months to become apparent. Methotrexate still remains the anchor drug in rheumatoid arthritis therapy, followed by salicylate and hydroxychloroquine. Administration of these drugs usually follows by serious adverse effects. Although there is an established theory that early initiation of DMARD therapy rheumatoid arthritis progression, considering all the adverse effects these drugs has with the early initiation of DMARD, really helps with the overall life as a question. So, we carried out study to investigate whether this early initiation of DMARD therapy really helps with the overall mental and physical quality of life of patients. And our main objective is to assess the relationship between the time initiation of DMARD and subsequent care-dependent quality of life in patients with rheumatoid arthritis. Now, let's delve into methodology. This outlines the specific approaches and techniques we use to conduct our research. This was the retrospective foundation of study and was set in the which data collection spanned just 2 weeks. We initially evaluated 100 patients, but we implemented criteria from 87 ensures robust and reliable data by accounting for potential non-population. All the participants were diagnosed with rheumatoid arthritis. We gathered data using an interview administered questionnaire, capturing demographic details and time of symptom onset to treatment. Polymer glycolysis using SNL6 standard questionnaire. The data were transferred to a spreadsheet and a score was given about the polymer glycolysis based on the answers to the questionnaire using an online tool. For analysis, data were transferred to genome software where we calculate the correlation coefficients to explore the relationship between delayed initiation of treatment and polymer glycolysis in both physical and mental health components. What are the findings? Out of 87 participants, 48.3% were over 60 years of age, and from them, 98.9% were females. One of the most influential findings of our study is the timeline for treatment initiation. On average, patients has begun treatment 2.96 years after the onset of rheumatoid arthritis with a considerable rate of age. Now, here where it gets interesting. We found that physical component score PCS actually increased the delayed treatment initiation, suggesting positive correlation. However, before jumping to the conclusion, it's important to note that this correlation was not statistically significant. On the flip side, the LCS, mental component score, showed a different trend. With delayed treatment initiation, LCS depicted reduction. Looking at the LCS, we find that emotional well-being, the critical component of LCS, showed the most significant difference. We have a negative correlation with delayed treatment initiation with p-value of 0.029 and scale one side correlation coefficient of negative 0.234. Although this trend is more promising, it also weak statistical significance. In a nutshell, our findings suggest that while there are multiple trends regarding the time of DMR initiation and its impact on physical and mental health components, these trends are not strong enough to be linked to statistically significant. Looking at past studies, we have observed that the relatively window of opportunity in early hospital disease, they have shown that early treatment significantly affects disease progression. Most of these disease studies primarily focus on the disease level, providing essential information that allows us to address the overall quality of life of the patient. We found that although early treatment favors better disease progression, it does not necessarily improve the overall quality of life. Therefore, we believe that holistic approaches are needed to develop the patient, including both impartition and downstream. Our study has some notable limitations, being retrospective, it relied on clinical investigations and also patient report, which would have affected accuracy. We suggest that future researchers to consider the possibility of given patients. Additionally, our findings are specific to a tertiary system which could potentially limit generalizability. Despite these limitations, the insights gained remain valuable and underscore the need for further research. I would also like to thank our research supervisor, our consultant, Dr. Chandra, and thank you.
Thank you very much. Thank you very much. It's an interesting presentation. And I would like to ask you one question related to the research idea. Is it the supervisor generated research idea or it's your research?
My name is because initially our idea. We were in a group, so we were curious about the novel pillars and this is from debilitating disease and which requires lifelong treatment. And also it gives serious side effects as well. So we were curious whether the treatment alone, the disease alone or treatment has been causing this this problem with patients. So, and we also discussed with the our supervisor and she also with her experience and experiences also.
Any other research similar research has been done.
Similar research has been done about the timeline of the DMARD initiation and also with the disease progression only, but they have not assessed about the increasing the quality or assessing the quality of life of patient in the realization of treatment.
During that period, when we relate the initiation of demands, up to that, what were your line with the patient? What were the therapeutic options or therapeutic options were there? Is it modifying the, have you implemented any therapeutic measures or anything to overcome symptoms?
The most of the patients are known about rehabilitation from complementary, and they are solely dependent on the demand therapy. Most of them.
Just more from what said during the those patients who are having spontaneous injury, other therapeutic intervention is not paid by
So it's fine.
in the sense that it is who are having demand therapy is not, then you can say these are outcomes. But if the patient who are having complications, interventions, it will modify those need to identify the bias or slow go back.
We only assess the quality demand therapy, but excluding other interventions, so we think that is fine.
And in a sample set, you did mention how you treated your patient. Was it all muscle arthritis specified in the clinic or was there included exclusion?
There are inclusion exclusion criteria. We selected patients aged 90 to 75 who were diagnosed with rheumatoid arthritis according to ACR 20 classification criteria. And we excluded the patients who lack the capacity consent and who give their clinical reports and also who has overlap syndrome. Thank you.
The feminist mark. The feminist mark.
Next up, we would like to invite Mr. Chandran S., who will be delivering the presentation on knowledge, attitudes, and practice of lifestyle modifications recommended for hypertension management among adult hypertensive patients in a tertiary care hospital in Sri Lanka.
Good evening, all of you. My name is Diagnostic. I'm here to present my research on knowledge, attitude, and practices of lifestyle modification recommended for hypertension management among other hypertensive patients in a tertiary care hospital in Sri Lanka. Hypertension is a common risk factor for cardiovascular disease and diabetes mellitus and renovascular disease, as well as many other systemic diseases which affects 1 billion people around the world in a drastic number. So to manage the hypertension, there should be pharmacological management and non-pharmacological management to achieve the desired therapeutic goals. We focus on the non-pharmacological management, and in India, lifestyle modification is the mainstay. Even though there are numerous studies on hypertension, there is a noticeable gap in addressing the gap with regard to lifestyle modifications for managing hypertension in Sri Lanka. Our objective is to evaluate the knowledge, attitude, and practices of the modification measures among other hypertension patients attending the hypertension clinic in the tertiary care hospital in Sri Lanka. We conducted a cross-sectional study at the hypertension clinic of teaching hospital TERTIARY. A structured patient administered questionnaire was used for the data collection. The questionnaire assessed the participants' demographic characteristics as well as the knowledge, attitude, and practices of their various lifestyle modifications. We used ANOVA and Pearson correlation tests to find the statistical significance between the demographic characteristics and the knowledge, attitude, and practices. Scores were calculated separately for the knowledge, attitude, and practices, and for our calculation purposes, we converted it into percentages. Then the calculated percentages were subcategorized into poor, fair, good, and excellent subcategories. Poor and fair categories we named as considered as satisfactory, and poor and fair outcome being considered unsatisfactory, and good and excellent subcategories were considered as satisfactory. This is our results on the knowledge of lifestyle modifications regarding hypertension management. Majority of 57% of patients show satisfactory outcome regarding their knowledge. When considering attitudes of the patient, like a great proportion of 95% of patients show unsatisfactory outcome, as well as practices of patients also unsatisfactory, and it was 80%. We also consider the statistical significance between the demographic variables and the knowledge, attitude, and practices of lifestyle modifications for the hypertension management. And where we analyzed and the p value was less than 0.05, we considered it a significance. Among that, occupation and last systolic blood pressure had a significance towards the attitude regarding hypertension management, as well as the monthly income and the last systolic blood pressure has the significance towards the knowledge. There were no any significance between practices and any demographic variables. So this was our research as I mentioned earlier in the slide. So as I already mentioned, the conclusions that 57% of the patient, 57.5% of the patient have satisfactory knowledge, and 94.7% of patients have unsatisfactory towards attitude, and 87.7% of patients have unsatisfactory outcome. As well as knowledge and attitudes were significantly associated with the recent systolic blood pressure reading. So our recommendation is implementing measures to improve the knowledge, attitude and practices of lifestyle modification measures in this population group is important. And such measures can be achieved through national campaigns on social media, television, and providing reliable resources of the internet, and increasing emphasis on educating hypertension patients who are attending to the clinic. Thank you.
Thank you very much. Nice presentation. One main question. You said it's good that excellent group is satisfactory, and for people unsatisfactory. The relationship of the perspective between fair and unsatisfactory. So, how do you?
Yes, madam. For that, we choose a couple of values depending on the previous research done on this. So,
The questionnaires were already previous, all you have, you have constructed any question.
we have modified the questionnaire, but we chose the questionnaire from the previous studies, and we have had some modifications
Why do you not have?
because the previous research is done on like different countries. Each state you do like something related or countries like amount of salt you have to do those questions being extra. Yeah.
One more question. Now, you said you have separated in your conclusions, if you go with the conclusions, maybe yeah, that's right. The last, yeah. Such measures can be achieved through national campaigns. Now, this particular population group was what was your sample, the area of the
The diagnosed hypertension patients attending to the PG hospital Peramani period.
maybe extrapolate to the whole,
Sorry, ma'am.
like the island by extrapolation can be done from that population. What is your acceptable population? What is the target population?
Like we our target also to emphasize on those patients.
Yes, so the last conclusion here, like we need to be here and advertise everybody.
Now, going back to point of what is the standardized measurement of the extensive knowledge attitudes and those things, if you are modified, standardized measurement are based on actual question responses, see whether they are appropriately understood, and then get at that, they are going without standard. We modify it. Then you also have to do the same thing to check the particular asking same thing as what the patient understands, how the response is. So we modify these things. Showing that comes out it is something that is cause an error.
In that way, we provide some difficulties in the clinical patients where we get to understand the questions, and we actually interfere in them, and we need to explain some questions, and we may have difficulties.
So this is a question that you administer that you ask question and then you fill out the form.
It was initially self-administered questionnaire, but For some patients, because of they didn't bring spectacles, and some patients were in a hurry to go to the clinic, and in some patients we warning to get.
So do you think when you make that ingredients and a lot of bias in the will pick up?
So it's
When you fill out the questionnaire based on somebody with the answers, then they increase your biases and let
yes, very much personal bias.
and also like about this self-predictive suicide was employed
We get together as a group and also with the discussion with our coordinator, Dr. and we,
of my part.
yes, yes.
Go back to the cycle slide. Go back to the title, right? Your supervisor is Professor Salih. His name is not to receive among doctor. Yeah, so it is ethically wrong to exclude him and not give him an ownership. So the supervisor should be included always in the as a norm.
We now
These are the points. The exams, these are the main way of
thank you.
Ladies and gentlemen, please welcome our next presenter, Ms. Choki, to present their research on complementary and coordinated methods usage among chronic kidney disease patients in a tertiary care setting.
Hello. Good afternoon, distinguished judges, honorable guests, and media friends. I'm Ms. Chuki, and I am proudly representing my team to present our research topic, complementary and alternative medicine usage among chronic kidney disease patients in tertiary care setting. So we know that chronic kidney disease is one of the most prevalent disease conditions that's affecting millions of Sri Lankans out here, especially with this the high prevalence of diabetes and hypertension, which have been found to be one of the common causes of CKD. According to the World Health Organization research as well, it has been found out that CKD is one of the most prevalent. CKD burden is found in low and middle income countries, especially with. I'm sorry for the technical disturbance. So according to the research that has been carried out by the World Health Organization, it has been found out that CKD is highly prevalent in low and middle income countries, and particularly in Sri Lanka, it is affecting 15 to 20% of the population. And along with that, we have discovered that though there is no scientific research at the moment, particularly delving into the use of complementary medicine like chronic disease patients in Sri Lanka, there are many patients who are actively seeking our complementary and alternative medicine options because of the fact that the final outcome of chronic kidney disease leads to use of renal deficiency therapy as the ultimate result, which is a daunting option for many of the patients. So as a result, they look for something that can help them bridge the gap where conventional Western medicine has not been able to. So complementary and alternative medicine, which are now referring to which are the presentation as CAM, is a broad spectrum of medical practices which are not included in the conventional Western medicine. And the commonly identified CAM practices are biomolecular techniques, treatments based on biology, where we have animal and plant-based extracts, along with that, body-based manipulative techniques, energy treatments, and comprehensive healthcare systems like Ayurvedic medicine, Unani medicine, and homeopathy. So we have, as I mentioned before, though there are some available research on the use of CAM in disease conditions like diabetes and cancer, there is a significant lack of research about CAM use in CKD patients, in particular in Sri Lanka. So as a result, our research has been an attempt to try to delve further into the prevalence and factors of complementary and alternative medicine use among the CKD patients visiting the tertiary care centers, and also to figure out the factors associated with the use of complementary and alternative medicines. Moving on, our methodology, which the design of the study as a descriptive cross-sectional study, where we chose the CKD clinics at Teaching Hospital, Peridenia, and National Cancer Hospital as our study setting, and we had collected data via paper-based questionnaire, which were pre-tested on a pilot group of patients before being handed out and before collecting data from 201 participants. The data which was collected was then fed into Excel spreadsheets and then we analyzed them using the free and open source software called DIAGNOSTIC. And ethical clearance was taken by the Institute of the Faculty of Medicine, University of California. And then in results, we have found we have categorized we have presented the results of the way as the categorical variables have been presented as frequencies and percentages, and the continuous variables have been presented as mean and standard deviations. And we have found that despite CKD being one of the most common diseases affecting primarily females, in our study, most of the patients who were using CAM were males, and along with that, main age, that is the majority of the population from our sample were about 50 years old, and the sizable chunk of people who were using CAM practices were Sinhalese, mostly coming from economically challenged backgrounds. And we found that the main duration of the disease was 3.96 years, with a range of 4 months to 20 years. So, as you can see here, most of the patients who had stage 4 and 5 CKD were using the CAM mostly. Along with that, we found that 44 of 201 participants were using CAM actively. They were using CAM, and from there, some were IPAS users and some were actively using CAM practices. And then we found that the most popular CAM practices were biologically based therapies, which were LANKA-based extracts, and the least popular were body-based immunity therapies. We also found that while assessing the satisfaction of the CAM users in the CKD patients, many people, more than 50% of the population, were happy with how the CAM was affecting their disease progression. And along with that, unsurprisingly, we found out that many had not discussed about the use of CAM with their physicians. So, moving on, these are the factors that we considered, which were as associations for the CAM use in coronary disease, and we found that amongst all the factors, only the duration of the disease, the long-standing duration of the disease, was a significant association with p-value of less than 0.33, and other factors didn't have a significant association. So from the study, we were able to conclude that despite a lack of evidence on the use of CAM, many people were actually taking functional medicine alternatives in adjunctive or even in place of Western medicine. And only a minority discussed about the CAM use with physicians. And along with that, there is a significant association with the long duration of disease and CAM usage. Now, like any good detective story, our research study had its own twists and turns, and we had some limitations that we didn't address. So, what's the limitation? So, a few of the limitations that we have presented here are small population size, with the limited time for data collection. Along with that, selection bias as well, where the clinics are depicted by the based in urban areas. So, we felt that if we had carried out the research in some rural population, in rural parts of India, the results would have been significantly different. And along with that, while there are data collection as well as information based from other researchers, we have found that patients are not very cooperative when they are disclosing information regarding the CAM use. And some of the limitations that haven't been mentioned here are the geographical distribution of the popularity of certain CAM practices. We said not here, we discovered that the most commonly used CAM practices are biologically based therapies, and that have differed in other parts of Sri Lanka as well. So there were two limitations that we address. And from the research that we have carried out, we were only able to sketch at the surface of the prevalence of CAM practice in Sri Lanka, and we hope that this can lead to an open discussion about the CAM use between the patients and their physicians, so that a more holistic approach towards the treatment of CKD can be carried out as well. And we think that we can encourage other researchers as well to delve into the field of complementary alternative medicine, so that the disease progression can be prevented properly. And with that, I would like to thank the patients of CKD clinics for their cooperation, as well as the Timecodes of Teaching Hospital Area and National Hospital KANDY for giving us their community support, and the directors of Teaching Hospital Area and National Hospital KANDY. So, I'm sorry for taking up extra time. Thank you so much. I'm going to questions.
Thank you very much. Very interesting paper. I did not know.
Okay.
What is the reason?
Thank you for the question, ma'am. The sole reason that we picked this topic in particular was that while we were doing our endoscopy findings in the English from the patients, we figured out that many of the patients were talking about using care practices in adjunct to or even in place of the medicine that they were getting in the hospital, because especially during corona periods, like patients talk about how they had other conditions. And on top of that, like I come from Bhutan where there are a lot of complementary medical practices that are being carried out. So we thought that bringing all these ideas together to try to see how it would be effective.
What was the sample size?
Sample size, actually we have calculated it as a final sample size being 163 patients because of the limited time collection period to collect data, but we were able to collect 240 patients.
Okay, so the final conclusion is that maybe the is why did it?
I think that it would be due to the fact that since the patients are with disease for a long duration of time, they might not be seeing any significant like improvements with the pre-existing treatments that they're getting. And their physical practice they could be mentally affected by the diseases, but because the treatment that they are doing so in order to kind of help them come to terms with how the disease is progressing, they try to seek out the disease to in order to try to give them hope, and it gives them a sense of agency in order to.
So, and also in your home, you have equal number of parallel numbers of state transportation to 5 patients.
No, so that was entirely dependent on the patients where they are living.
Yes, my investigation how patients in 1 month
Since can you repeat the question?
patients come to your clinics, they may be patients with more advanced disease. Therefore, with the longer duration of time, disease, for longer duration of time, therefore, your numbers are going to those groups in your study as opposed to being a representation of what is there in the population.
Yes, so that was one of the limitations that we could address in the studies.
And whose idea was this study?
We are proud to say that me and my teammates came up with the idea, and our supervisor helped us to formulate the questionnaire as well and to bring the
So it's based on your observations in MSQP that
Yes.
and
Thanks so much. Thank you, ma'am.
is it possible to ask the question?
Our next presenter is Hair Instrument will now present their research on descriptive study of diagnostic field of routine electrocardiography in hypertension. The floor is yours.
So good evening to all everyone present. Our study is the descriptive study of diagnostic field of routine electrocardiography in hypertension. So first of all, what is hypertension? Hypertension is the elevation of blood pressure more than 180 according to American College of Cardiology. Hypertension leads to most of the health challenges as well know. It's the leading factor for heart diseases, cardiac diseases, and stroke and premature over 1 million of people worldwide have hypertension. But the problem is most of the patients do not show any symptoms. Therefore, there is the chance of early treatments and they get serious complications after that. But hypertension causes some of the structural changes that mainly reflect the functional state of the heart and the vascular system of the body. Therefore, this characteristic using cardiacs. So, among hypertensives, 2/3 live in the lower and middle income countries. This figure is supposed to stand at 29% by next year, between nation one of the developing countries. So, as you all know, Sri Lanka is a South Asian developing country, which has a prevalence of hypertension in all Sri Lankans is around 51%. So the major objective was to identify the diagnostic field of this multi-cardiography in hypertensive patients who are present in the TERTIARY Teaching Hospital Hypertensive Clinic at the Medical University. So for that, we discovered our specific objective was to discover the parametric changes in rate, rigor, period duration, QT interval, TD amplitude, and then hypertrophy. And in the hypertensive patients and to identify how patients have these variable, these changes in variables. And there are a number of patients who had at least one variable change about the stated variables. That is the diagnostic field, innovation, age groups, and gender. So as for the methodology, we selected 202 participants, researchers, who presented the hypertensive and we made the word C. And this was a distributed retrospective cross-sectional study. Our population was between the 18 to 60 years, and in 1939, there was no females were presented, and only there were 4 females. And in 4 to 6 years age group, there were 60 females and 135 females, with a total of 198. And these were the electronic variables we mentioned previously. And the way we calculated these variables was great, as you all know. We calculated large space in between 2 URs pixels and it was divided by 300. And normal period duration is considered as 0.12 to 0.2 seconds. And the periodic interval was measured in here. And it is the normal periodic interval was 350 to 450 milliseconds. And TDA suggested that it is more than 10 millimeters in length. We suggest that it was high. And in women, it was more than, it was abnormal, it is more than 8 millimeters. And when we was calculated using this honest criteria of the line criteria. So these are the results we got. In data figure, around 20% patients showed sinus arrhythmia, while 79% showed sinus rhythm. And in this patients who presented with sinus arrhythmias, they were more females than men. And in linear duration, there was 8.42% who were had abnormal periods, and their they all had short period durations. The short period durations was common in females and also for 6 years age group. And interior amplitude, 90.02% had normal TAs, while others had high TA amplitude. It was also common in females in 4 to 6 years age group. Left ventricular hypertrophy was shown on 3 subjects from the population. One was male and below females, and those were also in the 4 to 6 years age group. And included duration is normally 65% and abnormally 34%. And they are shown that prolonged included durations are more common in female population as well as they also be 46 age group. So the conclusion was there's increased incidence of lacking disease abnormalism among females in the age group of 46 years. And diagnostically, there is possible practice one electrocardiogram abnormality was 50% in both 18 to 39 years and 4 to 6 age groups. So the diagnostic period of electrocardiogram is considerable, but the results were equal in both age groups. And this may clearly also hypertension is complications. And so we suggested the active hypertension regardless of age, but we should pay more attention to symptoms. There is only one study which was most similar to our study, and there was 51% in the 15 to 44 age group. And the diagnostic period was increasing towards the elderly ages. And then the subjects had a slightly increased chance of having abnormal family. In comparison to other study, we got that females are having more chance of having abnormalities. So this is we are on this part of the and this is our analysis.
Thank you very much. A very tough Heidi. With your results and conclusions, what have you done now?
According to our research and conclusion, it's better if we can approach the patient's management by early. We can have some pharmacological changes and lifestyle changes early on, and that will be better for the management.
These are more patients.
Both patients.
Both patients are there. So there may be difference in those two techniques. There are some diseases that will more patients, yeah, is without the same.
In one patients here, reasons. We selected in one patients whether they have hypertension.
So it's a very heterogeneous group.
So the title of your is the diagnostic field of electrocardiogram. So actually we'll be talking about the diagnostic value of ECG. So then you exclude patients who are already diagnosed with what is your exclusion?
We excluded the patients who had previously any cardiac problems such as MRIs, cardiology doctors, we excluded them. And also we excluded the patients who are more than 6 years of age. And, but we do not exclude patients that other diseases, diabetes, and such.
What about patients on drugs, for example, Renal
I think
so will that be a question?
yes.
Then the duration of long station time is categorize your patient based on the duration of the
And also, we included the patients who were diagnosed with admission more than 6 months of duration, but are
My question is, if there is another hypertension for 1 year post 20 years, we have significantly different cardiac profile, and therefore, so ideal is
our events at the area of getting hypertension and the ECG connected with something because we know that hypertension causes cardiac changes, and as ECG is really available and unprecedented, if there's any kind of thing that we can use for diagnosis and the communications of ECGs, and then we discuss with our supervisor and the community environmentalists, we choose the right. Yes, wonderful. Our final presenter for this session is Ms. Priyasekara WGDM, who will be delivering the presentation on temporal trends and epidemiological analysis of dengue in Kandy from 2017 to 2023, Sri Lanka, a retrospective study.
Good afternoon, everyone. I'm Priyasekara, infill candidate. My study is temporal trends and epidemiological analysis of dengue in Kandy from 2017 to 2023, Sri Lanka, a retrospective study. These are my supervisors, Professor Noor, co-supervisor Dr. Mutugala, and collaborator Dr. Akram. Here, this is my outline. Dengue. Dengue is a significant public health issue in Sri Lanka, particularly in urban areas like Kandy. Over the past decades, the region has experienced periodic outbreaks. There are several factors influencing the dengue incidents, such as climate conditions, urbanization, better control efforts. My study is focused on the importance of monitoring the dengue trends in Canada, providing insight into fluctuations in case numbers, COVID-19 impact on surveillance and reporting. The analysis period was 2017 to 2023. Here is the objective of my study to examine temporal trends in dengue incidents and to identify monthly and yearly incidence variations. My study design was retrospective analysis, and the study settings are infection control unit and viral laboratory of National Hospital, Canada. Study combination include clinically suspected and laboratory confirmed dengue cases from 2017 to 2023. The analysis data was analyzed by using ASF version 25 and Microsoft Excel 2017. Here this is the most important part of my study, is a discussion. The graph shows monthly trend of dengue cases in family from 2017 to 2023. Here you can see the significant peak can be seen in 2017, and there is lack of data in 2020 because of the COVID-19 pandemic. And also you can see regarding the seasonal pattern on 6-year period, dengue consistently peak from June to October each year. Here, this is the yearly distribution of dengue cases in Kandy. You can see here the highest number of cases has reported in 2017, but there is significant drop in 2018 because of there is no extreme pandemic in 2017, so the prevention measures are applied for in 2018. The number of cases has dropped because of that, and also there is another reason for that. The number of cases has reduced due to previous exposure in seropalate. The human already has natural immunity in their body. And you can see in 2020 there is no data available. And the minimum number of cases has reported in 2021. It is also maybe due to lack of reporting in 2021 due to COVID-19 pandemic. And also the people were in the lockdown period, so it may be affected for the reduced number of cases. And after that, from 2020 to 2023, there is a gradual increase. Here is the monthly distribution of dengue-related disease in Kandy. Here also you can see from 2020, there is death has reported current. Here these are the yearly distribution of dengue-related in Kandy. You can see the highest number in 2017. And because of reasons, the number of deaths also has reduced in 2018. The same number of deaths has reported in 2019, 2022, and 2023. Here these are the annual statistics of clinically suspected, laboratory confirmed, total number of dengue cases and related death in Kandy from 2017 to 2023. Here these are my conclusions and recommendations. The conclusions are dengue cases peak from June to October each year, and COVID-19 had an impact on their collection and reporting. The recommendations are vigilant surveillance and targeted intervention during this peak month are essential to effectively reduce dengue incidence. There are several limitations in our study. Data collected due to COVID-19 pandemic and affected the continuity and accuracy of the data analysis. As a retrospective study, may have inconsistencies. Clinical suspected cases might include other fabric influenza. The data is collected from National Hospital Kandy, which may not represent the entire population of Kandy or other areas. And here we only focus seasonal and yearly variations. These are the references which I used. And I want to acknowledge my supervisor, co-supervisor, and collaborator, and all the staff members of biology, laboratory, National Hospital Kandy, and all the staff members of infectious control unit, National Hospital Kandy, and the hygiene community, academic medicine, and University of Kerala. Thank you.
Next, one question of you. Took these patients from the took these data from Kandy hospitals. So all these hospital admissions.
Yes, madam. I got I have ongoing dengue research molecular characterization. And simultaneously, I and my supervisor and the collaborator ordered to analyze trend analysis. Then we got the permission from the director of National Hospital Kandy. Then we got the data.
So it might not directly represent the population.
Yeah, that is the reputation. Sorry?
Thank you for that question. Yeah, so so in third one, to say vigilant surveillance and targeted intervention in this months are essential to reduce dengue incidence. Can you say that based on we are not interventions or the effective trends, none of that. Do that, do that. Can you say that based on the
That is my recommendation to expand this study.
recommendation of the study?
Yeah.
So the methodology is not incorporated in your
No, not yet.
Sometimes the hospitalization maybe due to the utilization factors, more virulent, the more virulent species might cause more hospital admission, might change the trend of the population studies or prediction. You will look at the variance of the variance that they are able to see.
Yes, I have ongoing research on that, so I will find.
So, and also any idea about the age group, like some vegetable novels or
In that data, there is no categorization of age group. Only they just the number of cases. The older cases data infectious control unit in Kandy hospital.
one last thing.
Yeah.
Yeah, the currency based on fact that these are major diagnostic. But in the meantime, geographical locations from which these patients came from, these are results that there are focused that training also already for intervention. We need to move back into it. The the connection even talking abbreviation is there. So was the geographical data that you can overlay on this?
By models and that study, we have to take permission immediately and find out the DHT and other things to find their addresses and where they are located.
So if we looking at the
Basically, I know the end data.
and also the checklist is project is over now and contemporary.
It's combined ideas.
Yeah, concentrate data so visible in habitat presentation. Those again, they can even parameters. So that she, I'm not sure if
She is a higher student, infield candidate.
private, but these are being for walls. They are constructed saying,
I don't think it's been proven.
yeah, that's it. Yeah, I think they're all separate.
There was a separate thing for post graduation.
That's right.
When they submit, so they are like undergraduate is separate.
Yeah.
We kindly request the final speaker to join us on stage to receive the certificate from our judges. We cordially invite Dr. Shantri Naik to present the certificate. Ms. Veera Sekhar, WGDM.
Thank you very much. Now, the board will invite Dr. Kiswara Ratnakar to present the rest of the session. We kindly request the remaining presenters to join us on stage in speaker order to receive their certificates. Ms. Aurora, UAN. Mr. Jonathan Chen. Ms. Shoki PD. And Ms. Hera Richard. Thank you very much. And that concludes the third and the final session of oral presentations for PEMSA 24.
We would like to extend our gratitude to our chairperson and judge for overseeing the excellent session.
Thus, we cordially invite Professor Fasina Nuri from the Department of Microbiology to come up on stage along with our session's chairperson and judge to award the certificates.
Thank you very much. Thus, the third comes to a close.